So welcome to the Symposium 4, I think Symposium on Neuroophthalmology. So it's my pleasure to introduce the first speaker, who's Professor Axel Petzold, who's a consultant neurologist from the National Hospital for Neurology and Neurosurgery, Queen Square, London. So Professor Petzold can take over.
Thank you. Can you hear me?
Yes, we can hear you very well.
Okay. Thank you very much for the invitation, Bim. Thank you for the introduction. And what I want to share with you is something which really has been a team effort, very much focused on optic neuritis. And Lega Pandit and I spoke 2 days ago. So what I will try in my talk to do is to focus it also very clinically on what hopefully people will find helpful in Sri Lanka. These are my disclosures. And to give you the story of ICON, ICON stands for International Consortium of Optic Neuritis. It really goes all back to something which Nancy Newman and Valerie Bius, these are the two new ophthalmologists in USA, have orchestrated. And what Nancy and Valerie have done is they negotiated with the Lancet Neurology a commissioned series of reviews. And these are the 3 reviews here. There are about imaging of the optic nerve, the optic neuritis, and the genetic causes. Within these 3 reviews, they were meant as a platform to support this paper ICON published on the diagnostic criteria. Then there had been a scientific commentary, an editorial, there had been 2 interviews, there had been 2 letter exchanges, and an author response. So just to put this into the context, the Lancet Neurology has given 11 papers to optic neuritis, if you want. And that is something which is unique in the history of the journal. And they thought it to be so important that they made it available on all of the Lancet websites and also made it available free for download. And that is because it was focused very much on the clinic. The way these criteria I will share with you today have been developed has been a Delphi process over a process of 3 years, and experts from around the world represented here discussed how can we approach what we all see around the world in a consensus way. Consensus was described or defined as 80% of all the experts present need to agree. And what has been special about this particular consortium was that it consisted about half of ophthalmologists and neurologists. And here we also have some neuroradiologists. And the reason for that is that the patients which come to clinic, of course, they all present with the visual loss, but they tend to cluster with some sort of pathology more towards neurologists. And that is what you discussed today in your symposium, that is in the context of multiple sclerosis. And they tend to cluster more towards ophthalmologists if they have a different way of how the optic neuritis presents. So we put all of that together to get a bit more of a holistic approach. And also because it is very, very important how the ophthalmologists and the neurologists work together. There are shared responsibilities. And you heard today how some of the disease-modifying treatments really are given and monitored by the neurologists. And there are other aspects where ophthalmology comes more into the picture. The diagnostic criteria are really very straightforward. We have 3 possibilities. Either it is definite optic neuritis, or it is possible optic neuritis, or it is not. To talk you through this, in this category of definite optic neuritis, clinically, we decided that there are 3 scenarios of increasing complexity. Scenario A is the most simple one. These are patients who present with subacute monocular loss, loss of color vision, pain on eye movement, which worsens typically as you move the eye, and clinically you see a relative afferent pupillary deficit. And a relative afferent pupillary deficit is something which you have your ophthalmoscope, you have a light, you just test by shining the light in one eye, 1, 2, 3. You wait a bit until the pupil dilates, you put it in again, and you see the constriction. 1, 2, 3. If this eye dilates, then there's an RAPD. That is clinical. Scenario B is more complex because in scenario B, there is no pain worsening in eye movements. And scenario C is even more complex because the loss of vision is binocular. And because that loss of vision is binocular, the RAPD becomes less reliable. With these three scenarios, you require paraclinical tests, which you may or you may not have available in your practice. And I will talk you through these tests. But it's important, it is massively important to acknowledge that you do not need these tests. So if they are not available, if you don't have an OCT or biomarkers, then you make a diagnosis on clinical grounds alone, and you call it possible optic neuritis. And there are very, very important reasons to why we decided to have this category of possible optic neuritis. It is because around the world, not everywhere, we may have immediate access to the paraclinical tests, but also because you may need to make a clinical decision on saving your patient's vision much, much quicker than waiting for the outcome of an MRI or a laboratory test. So it is massively important that you can make a diagnosis of optic neuritis on clinical grounds alone. Having spoken you through the three scenarios, I now will combine them with the tests if available. Hold on, before I do that, I come to the classification. The decision on the classification on the top level to separate monophasic from relapsing conditions was because of the long-term implications. So until now this morning, you were presented with multiple sclerosis, MOG, antibody disease, and these are all conditions which do require long-term immune suppression. Treatments are available. So within the typically relapsing forms of optic neuritis, we have decided to include these subtypes: aqua 0.4 optic neuritis, where you have the antibodies present; CRMP5, this is a paraneoplastic form of optic neuritis, to my knowledge only ever described with small cell lung cancer. Then you have the MOG optic neuritis, of which you heard a lot. Then you have multiple sclerosis optic neuritis, and there are exciting developments spearheaded by people developing the criteria. And then there are these three categories here. They are again only clinical if an optic neuritis behaves very autoimmune, but you don't yet have the antibody, maybe because it's not yet discovered. Then you can classify them as single isolated optic neuritis, relapsing isolated optic neuritis, and chronic relapsing. This is the steroid-dependent form. On the other side, you have optic neuritis, which clinically is monophasic, and that can happen typically after an infection, after vaccination, or in the context of a systemic disease. Now, I did tell you in the beginning that we have this panel of about 101 experts around the world. And at the very beginning of our Delphi process, we asked, what form of optic neuritis do you see in your clinical practice? And then we compiled a table. And there were about 164 different types of optic neuritis people see in their own practice around the world. And of course, this is too much to be put into a classification. So the idea of the Delphi process was to come to these type of categories which people can remember. But it's also to acknowledge that there's some forms, and for example, the Mayo Clinic is very, very advanced in GFAP disease. They may enter in here. Then we have a lot of Guillain-Barré in China, where you have GQ1B. And don't forget, GQ1B is not only expressed in the motor nerves around the eye, but also in the optic nerve. So GQ1B optic neuritis may come in there. But it does require maybe a bit more validation to be accepted in a future revision. And I'm sure there are some forms of optic neuritis more frequent in Sri Lanka than in the United Kingdom. So let me talk you through the 3 clinical scenarios again. And as your clinicians, I just want you to think what the diagnosis could be. The first case is a 34-year-old Caucasian woman. And 7 days ago, she had pain in the right eye, and that pain got worse when she moved the eye inwards and upwards. She lost color vision. So if she would look at the red color here, she would see it fainter or pinker or desaturated with the right eye. The visual acuity dropped a little bit. So these are the high contrast Snellen charts we use in the United Kingdom, 6/9 in the right eye, which is not normal, and 6/5 in the left eye, which is okay for a 34-year-old lady. There's a right RAPD. And if you take very good history, she also remembers fatigue, cognitive problems. She cannot multitask as good as she could, urinary incontinence. She feels depressed. And about 3 years ago, on her right side, there was some numbness, which lasted for about a month. And then there had been spontaneous recovery. When we tested the bloods, it was low in vitamin D. And of course, you heard a lot about that. We all live in a world where we work indoors all day, use cars, and have very little sun exposure. The MRI showed what is typical for dissemination in space and time. There were 3 non-synaptic gadolinium-enhancing lesions, and then the cerebrospinal fluid was not done. So at this point, I want you to think, what could it be? And keep that thought while I present the second case. So this is a patient I have now followed up for well over 20 years. I first seen him when I came to London about 1996. It's a 28-year Afro-Caribbean male patient who had painless loss of vision in his left eye. And the loss of vision was much more profound than the first case, 6/38. He also lost color vision. There was a very strong left RAPD. When he got steroids, vision recovered. But when steroids were stopped, there was another relapse. He had many episodes on both sides over these last 20 years. And when we did the OCT, optical coherence tomography, there was this inter-eye percentage difference of more than 5%. Remember 5, I will talk about it again. And on the MRI, he did have in several episodes where we did imaging a swollen nerve, and later when the nerve became atrophic, still there was enhancement for contrast. When eventually discovered by the Mayo Clinic, he then turned out to be one of the aquaporin 4 seropositive cases. That's the second case. Now let's to the third one. The third case is a 72-year-old man, retired, went for holidays to Vietnam. Then he had a severe febrile illness, did feel very, very unwell. And in fact, he felt so unwell that he came back to Holland. And about 2 to 3 weeks after he had this febrile illness, he lost vision in both eyes, down to PL, perception of light only. And clinically, there was no RAPD because vision loss was bilateral. But it's needless to say to you as clinicians that you can still test an RAPD in absence of that pupil reflex because you can test for accommodation. So what I do is I give people a little target to fixate on, like a blue dot, and I look at it. I come ever closer with this dot to fixate. And if the pupils constrict, then I know there's accommodation. And if there's accommodation with a smaller pupil on accommodation, then the pupil reflex on exposure to light and I do know that the afferent and the efferent system are otherwise okay, that's an indirect way of showing a bilateral RAPD. Very easy, only takes you 5 minutes or 5 seconds in clinic. This gentleman had very severe disc swelling. Here you see the photographs with the hemorrhages, the engorged veins on both sides. In fact, acutely, the swelling was so profound that all the fluid expanded through the nuclear layer, that's the outer nuclear layer, into the fovea. So this is CMO. And then at 6 months follow-up, of course, this recovered, but you look at the optic nerve, which is swollen here. It's very atrophic here. Again, here the swollen optic nerve with the wrinkles you see, also called pattern lines, here completely atrophic. So this patient did have no recovery of vision, did have steroids, but it has to be said the steroids were given 1.5 months after he already was completely blind and had no chance. So why I presented the 3 cases to you, the questions which may have gone through your mind are, for the first case, is this multiple sclerosis? For the second case, is this neuritis optica? And for the third case, what is it? But what I really wanted to do is to use these cases to share the 3 clinical scenarios ABC we introduced. And the first one is the painful loss of vision, monocular, subacute loss of vision, loss of color vision, RAPD. Scenario B is the same without the pain, and scenario C is binocular. And you remember the RAPD testing is unreliable, but there are other ways around it. And with this, I now come to the slide where we combine the clinical scenarios with the paraclinical tests. So here are the clinical scenarios ABC. You're very familiar with them now. And here come the paraclinical criteria. In the easy scenario A, you just need one of these tests. There are 2 tests on imaging, OCT and MRI, and 1 test which are biomarkers. So these are the validated antibodies, ACO.4, MOG, CRMP5, or the oligoclonal bands, which really much credit goes to the group in Barcelona for having put them back on the landmark. So the scenario A, you see someone clinically visit and you send off the bloods and you get one of these antibody bags positive, you're there with definite optic neuritis. And it does not matter when the antibody arrives. Scenario B, you need to have 2 of these tests, which are complementary. And it's important, it is very important to remember that for imaging tests, there is a difference between having them done acutely, where you have swelling of the optic nerve in MRI, contrast enhancement, or you have swelling of the optic disc on OCT. Or if you have these tests done in the chronic phase, that's about 3 months, 6 months, a year later, where then the optic nerve becomes atrophic on MRI, and you see signal increase, important to use fat suppressed sequences, or you see the atrophy in the OCT. And because most of us human beings are relatively symmetric, both hands are relatively equal in size, both eyes have relative equal nerve fiber layers and ganglion cells, if after such an episode there is more than 5% difference for your nerves or ganglion cells in the eyes, it is a good indication that there had been a process damaging the nerve. And this 5% difference is useful clinically because easier to remember the normal values, but it's also important because it is not influenced by many of the factors which make the interpretation of OCT data complex. So people with a high myopia, it is still the 5% difference right and left. People of different ethnic background, there are differences in the nerve fiber layer thickness between different ethnic backgrounds. It doesn't influence because the 5% still applies to the same person. So we looked in the UK biobank at about 72,000 people, and even in the context of comorbidities, it is reliable. It's easy to remember, and it is reliable. If you have your clinical scenarios and your paraclinical criteria, you can combine them. For scenario A, which is the most simple, one test is sufficient. For scenario B, you need 2 tests, which are of complementary modality. And for scenario C, one of these tests needs to be the MRI as the only way to look back at the chiasma, the optic tract, and so forth. But as I said, it's massively important to remember that you can make a diagnosis of possible optic neuritis and treat patients on clinical grounds alone. Now, how did we come to this 5% difference between the 2 optic nerves in OCT? This is based on 2 meta-analyses published both in the Lancet Neurology, and what it means is very, very simplified. If you want to measure the weight of someone, you put someone on a balance and it says 70 kilograms. That's my weight at the moment. Then you repeat the same weight after lunch. It's 70.4. You repeat the same weight in the evening. It is maybe 71. And then you repeat in the morning after breakfast, and it's maybe 70 kilograms. There's a small variation in the weight in the same person over day. But overall, around the world, we are very good in getting the kilograms right. So what it means for OCT, the measurement here is micrometer. That is a measure of thickness. And what is astonishing, it is the best I've seen in my life in MS research, the precision of it. Here we have about 10 years work from different groups around the world on time domain OCT. And if there is multiple sclerosis atrophy, it is 20.1 micrometer atrophy in affected eye. Then there's a gap. There's development OCT. So this is spectral domain OCT, slightly different balance in that analogy. Again, all groups around the world with different patient large numbers. Look at that, 20.38. So it is almost to the decimal point identical. And that is, in terms of reproducibility, on an individual patient level, the best I've ever seen for any of the measures in multiple sclerosis. If you then look at all the various layers, and by now you will have figured out that the background of my slide is an OCT. So in red is the nerve fiber layer, then in gray you have the ganglion cell layer, this is the outer nuclear layer, and so forth, where Bruch's membrane is here. Then you can see the effect size is small for most of them. In green is the nerve fiber layer disc, in purple are the ganglion cells in the macula. So that's here. These are the only 2 measures which are really super big in effect size. So that is why we included these 2 and decided on this 5% as a reasonable sensitive measure. So how did we get there? Well, it is clinically, we had 3 years time to ask 100 experts about their opinion on a large number of cases several times. And we asked, for example, in these different cases, how keen are you to give this patient immune suppression on what we call a Likert scale, 1 to 5, where 1 means no, I don't want to give immune suppression, and 5 means yes, very much. And then look at these 2 categories where I said autoimmune versus monophasic, let's say post-infectious optic neuritis. Most of the experts, we had about 900 responses here, were very, very keen to give immune suppression in the autoimmune conditions. This is the median, this is the 25%, and then there's some of the outliers. Some people would say, well, we don't necessarily need to, but we all know that. There is no one in this audience who hasn't heard that some colleagues say in MS, maybe we don't need. Maybe this opinion has changed over the last 20 years, and maybe it's for the better that we actually do treat. But I think hand to heart, we all remember the time with the interference when not everyone was convinced. And that is what transpires here, that not everyone does the same, but there is a consensus on treating these. Similar if it is post-infectious. Most people say, no, we don't need to do that. And the classical scenario would be, for example, ADEM in children. And for this, we had a 95% consensus agreement. So it is relevant for patient management, massively relevant. And these are the patients you see in your clinic. At the first level, you need to make this difference. Is it likely to relapse? Is it likely to be monophasic? Because that is then what will determine how do you work together with ophthalmologists and neurologists, and what is everyone doing. So how is the agreement between these two groups of doctors? Here the neurologists, here the ophthalmologists. Blue are the autoimmune conditions, green the monophasic post-infectious, and you can see the distribution is very, very similar. And not surprisingly, neurologists have a little bit more of an elaborated differential diagnosis. Next question. How is the agreement between continents? And very reassuring, again, the blue, which are the autoimmune conditions between Africa, Asia, Europe, South America, very, very similar to the green ones, the post-infectious. But you notice, for example, in Africa, the purple area is a bit stronger, and these are the nutritional conditions. And that does make sense because depending on the type of patients we see, we think different, and nutritional toxic problems are more frequent in Africa. And then look at North America, the yellow area, that are the genetic causes. And that is where Nancy Newman and people involved with Leber's hereditary optic neuropathy, and there's a lobby for genetic conditions. So that is more frequently thought of in North America. But that is entirely acceptable and normal, because as doctors, it depends where we work in the world, what type of person we see, and what is going through our own mind. So just to summarize everything, you were absolutely right. The first case which I presented to you was multiple sclerosis optic neuritis in the 34-year young woman. And I just used it to introduce scenario A to you. You also were right. The second case was neuromyelitis optic neuritis. And that is this Afro-Caribbean patient who was seropositive. But I introduced it to use scenario B. And finally, the unfortunate retired gentleman who went for holiday to Vietnam developed dengue fever. And following dengue fever, he had this binocular post-infectious optic neuritis. And that was scenario C. With that, I give you the overall summary. The classification really was based on a clinical approach to prioritize clinical management. I gave you the ICON 22 diagnostic criteria, and I gave you the ICON 22 classification. And I acknowledge that this will need to be revised in the future. New categories may be considered, and sensitivity and specificity, of course, need to be optimized. And with this, I also want to point you to this survey we are currently doing. It would have been wonderful to be in Sri Lanka today. And what we are trying to do here is to use the criteria to define the different subgroups of optic neuritis. And if you want to participate, because we have no cases yet from Sri Lanka, I would be very grateful. With this, I thank you for your attention. Oh, yeah, thank you.
Thank you very much for that excellent talk, Professor Petzold. I think we can entertain one or two questions from the audience.
Hi, Giancarlo Comi speaking. Thank you so much for this so clear and so informative lecture. My question is about cryon, because this is a bit not well defined. If I understood, you mentioned that probably in this category we have a mixture of other maybe autoimmune disorders that may be characterized by different antigens playing a role. What is your view about this condition? And a bit related to that, when we may really be confident with this diagnosis, because usually we delay the diagnosis because we require some follow-up before that we have this label in place.
Professor Petzold, I hope you heard the question. Is he still there? Hello? You connected now. I think he's got disconnected. Let's move on with, because of concerns of time. Shall we move on to the next?
Our next speaker is John Chen from USA. He'll be speaking on optic neuritis in MOGAD. Over to you, Professor John Chen.
Hello everyone. I'm John Chen. I'm one of the neuro-ophthalmologists at the Mayo Clinic, and I really enjoyed Dr. Petzold's talk. I think that sets up this nicely. He talked about kind of the variety of optic neuritis, including MS, NMO, MOGAD, and I know with this conference you've heard a lot about MOGAD. Now what I like to do is just kind of focus in on optic neuritis just from MOGAD. So we'll take the next 25 minutes or so just chatting just about MOGAD optic neuritis, the clinical features. Just going back to that question about CRYON, it's interesting, MOGAD probably explains about 50% of what was previously idiopathic CRYON. So again, CRYON is that chronic relapsing inflammatory optic neuropathy that's often steroid responsive but steroid dependent. And we now know that MOG actually explains about 50%. The other 50% are still idiopathic, but it's important to rule out other steroid responsive optic neuropathies like sarcoidosis and other etiologies like that. And there's probably other antibodies that we just don't know yet. But now let's just go ahead and focus on MOGAD. I'm a consultant to UCB and Horizon, but really won't have any relationship for this talk. And so we're going to talk about the characteristics of optic neuritis that kind of make you think about MOGAD and how it differs from MS and NMOSD. We'll review OCT and MRI findings in MOGAD, and we'll discuss treatments of MOGAD optic neuritis. So we all know the optic neuritis treatment trial. It really was a landmark clinical trial, very, very important, that was published in New England Journal of Medicine in 1992. And its main goal was to evaluate corticosteroids and the risk of MS after optic neuritis. And essentially it found that 50% of optic neuritis is from MS. It really describes the classic typical features of optic neuritis that, again, Dr. Petzold went over, where 92% of patients are going to pain with eye movements. And of course, that's helpful for making that diagnosis of optic neuritis. 2/3 of the time, the disc is normal because it's a retrobulbar optic neuritis. And when there is disc edema, it tends to be more mild, at least for your classic typical optic neuritis. Fortunately, vision improves after optic neuritis, usually over 1 to 3 months. 92% of patients actually improved to 20/40 or better, and only 3% of patients with typical optic neuritis ended up with that poor vision of 2200 worse or legally blind. And what the ONTT found is that high-dose IV methylprednisolone quickens recovery, but does not actually change the visual outcome of this large cohort of about 465 patients with optic neuritis that they evaluated. But really what the ONTT focused on, not intentionally, but what was incorporated in the trial was mostly typical optic neuritis. Of course, we now know that there's NMOSD with the biomarker of aquaporin 4 and MOGAD with the biomarker of MOG. At the time of the ONTT, we knew about NMO, but we had no biomarker. We didn't have aquaporin 4 antibodies. And of course, we didn't know MOGAD even existed until around 2015. And again, the trial was completed in 1991, so we didn't even know MOGAD existed. Again, the ONTT completed in 1991. Since the completion of the trial in about 2018 or so, we went back and actually looked at the serum from patients from the ONTT, and about a third of the patients had some remaining serum. 177 patients had serum remaining, and we actually tested to see how many of these patients had aquaporin 4 antibodies, how many had MOG antibodies, and you can see that none of them had aquaporin 4 and only 2% had MOG. And that's part of the inclusion criteria was it had to be unilateral optic neuritis, first-time optic neuritis. So a lot of these patients were excluded because MOG often likes to cause bilateral optic neuritis. So essentially, what it's telling us is the ONTT provides excellent details of MS and typical optic neuritis, but not so much for NMOSD or MOGAD. And so for the remaining of this talk, we're just going to really hone in on MOGAD, but of course, compare it to MS and NMOSD. So MOGAD, again, you've heard a lot about MOGAD in this wonderful conference at Sri Lanka, but we know it can affect any age. We've seen it as young as 6 months old as 82. The median age is 33. And it's an important cause of demyelinating attacks in children, making up over 20% of attacks in children, and probably about 5% of demyelinating attacks in adults. Unlike NMO and MS, the female to male ratio is much closer to 1:1. We recently did a population-based incidence of optic neuritis, looking at how common aquaporin 4 and MOG were in a population-based setting using the Rochester Epidemiology Project. And so that's important because it's not just looking at patients seen at the Mayo Clinic, which obviously has a very large referral bias toward MOG and NMO, but using the Rochester Epidemiology Project, we can actually look at these entities from a population-based kind of mechanism. And what we found is that in Olmsted County, which is predominantly a Caucasian white population, we found that 50% were MS, 31% were idiopathic, 6% were MOGAD, and 3% were NMOSD. So at least in a predominantly Caucasian white population, MOGAD was about 2 times more common than NMO, but almost 10-fold less common than MS. Of course, that's going to be very different than other areas. Like I know in Sri Lanka, you have a lot of MOGAD based on collaborations that we've had with the Mayo Clinic looking at MOG antibodies in Sri Lanka. So in terms of features of MOGAD, again, it only makes up 6% of optic neuritis in our population. We have to look for features that make us think that this is possibly MOGAD optic neuritis. So it's going to be bilateral, much more common than even NMOSD. It's about 50% bilateral at presentation compared to 20% in NMOSD, less than 5% in MS. It's recurrent in 50% of cases, and we talked about how some cases are steroid dependent and how it explains about 50% of cases of chronic relapsing inflammatory optic neuropathy. Another very striking feature is the disc edema, and I think that tends to allow us to set it apart at times compared to NMOSD and MS. Disc edema is present in 80% of the time in MOGAD compared to only a third or maybe a little less than a third for NMOSD and about a third for MS. And when there's disc edema in MS and NMOSD, it tends to be mild, whereas in MOGAD, it can be more severe. There can be peripapilar hemorrhages in a subset of patients, much more commonly in MOGAD than NMOSD and MS. We've talked about OCT that Dr. Petzold introduced, and it's very helpful because it can actually quantify the amount of disc swelling by measuring the peripapilar RNFL. And so this is actually an OCT image of my own eye taken undilated, takes only about 30 seconds to do. But one important value that we can get is this is the optic nerve here, we can actually measure that thickness of the peripapilar RNFL. And again, quantify the amount of disc edema during an acute optic neuritis. And so this is just a classic patient with MOGAD optic neuritis affecting the left eye. you can see this thickness of 215 microns compared to the other eye, which is only 97. So you're seeing over 100 micron increase in the RNFO thickness during that acute optic neuritis from MOGAD, compared to this patient with MS who has optic neuritis in the right eye, which we couldn't see visible disc edema on examination, but OCT shows there's a 9 micron increase, 109 compared to 100 microns in the left. So about a 9 micron increase in that right eye in MS. So again, this profound swelling that we see in MOGAD, much less swelling in MS. And we actually looked at a cohort of almost 100 MOGAD patients, 51 MS patients, to see if we could stratify and differentiate MOGAD optic neuritis from MS optic neuritis based on the amount of thickening during an acute optic neuritis attack. And what we found is that MOGAD, you could see here that the median RNFL thickness was 164 microns compared to only 103 in MS. And using a receiver operating characteristic curve, we found a AUC of 0.81, and that 118 microns maximized the UDEX index and essentially found about an 80% accuracy in differentiating MOGAD from MS. So essentially this cutoff of 118 here, you're going to be 74% sensitive and 82% specific for MOGAD compared to MS, which tends to cluster below 118 microns in terms of total thickness. And if you have a higher cutoff of 175 microns, you can see that it's much more specific for MOGAD. We're still picking up about 45% of cases, but very rarely does MS cause that much thickening. So you can see here, if you've got a thickness of about 200 microns, chances are that's going to be MOGAD, and it's pretty rare for MS to cause that much thickening. And so these are some cutoffs that you can use in clinic. If you have a patient with optic neuritis and you've got a thickness of 175 microns, most likely that's going to be MOGAD. And we also looked at the estimated RNFL thickening by using the contralateral eye as an estimate in terms of how much it thickened during the attack. And again, MOGAD causes more thickening, 45 microns median compared to 7.5 for MS. And we actually looked at cutoffs. We found that 10 micron cutoff thickening, and that's about what you can visibly see. You can see that 87% of MOGAD eyes had that 10 micron thickening compared to only about a third of MS. So it matches, exactly what we see on exam, where we always say about 80% of MOGAD eyes, we can see visible thickening. A third of MS eyes, you can see visible thickening. Another important cutoff is 5 micron thickening. And it was seen in 100% of MOGAD eyes had at least 5 microns of thickening. Only 50% of MS eyes had that amount of thickening. And that's important because the test-retest variability in OCT is 5 microns. And therefore, OCT is very sensitive in confirming optic neuritis in MOGAD, less so for MS. And that's actually important because we incorporated OCT in the MOGAD rozanoliximab clinical trial. We actually used OCT RNFL thickening of at least 10 microns as an objective sign of optic neuritis. And I think it's the first time that OCT has ever been used looking at that acute swelling as an objective sign of optic neuritis. First time it's ever been incorporated into a randomized clinical trial. And it was largely based on some of this data here. And again, this was a large international study, including groups in around the US, Israel, and many others to kind of come up with this data. So again, stepping through these clinical characteristics of optic neuritis, we talked about disc edema. MRI findings are another key that are helpful. And there are some MRI clues to make you think that this is MOGAD optic neuritis. With MOGAD optic neuritis, they tend to have this optic nerve sheath enhancement. They tend to have so much enhancement that in about 50% of the time, it extends into the peribulbar fat, which we call perineural enhancement. MOGAD optic neuritis likes to cause bilateral enhancement in about 50% of cases, and about 80 to 90% of the time, it's a long optic nerve lesion extending over 50% of the optic nerve, which is very different from MS, which tends to cause much shorter segments of enhancement. So if you see long segment enhancement, you want to think about MOGAD or possibly NMOSD. And then this finding here, this perineural enhancement seen in 50% of MOGAD is pretty specific for MOGAD. We don't tend to see that with NMO or MS. And so these radiologic features are important. In terms of, well, let's just go back before we talk about vision loss. Again, these are some key features that make you want to think that this is MOGAD. This is important because these features are actually somewhat incorporated into the MOGAD International Diagnostic Criteria. So as I'm sure you heard about yesterday or earlier today, for MOGAD, to make the diagnosis, if you've got a very high titer and optic neuritis, you can make your diagnosis there and then. However, if you've got a low MOG titer of, let's say, 1 to 20, 1 to 40, you actually need to have one of these features that are more characteristic of MOGAD to be more confident that this is MOGAD optic neuritis. Again, because MOGAD is, tenfold less common than MS. Our antibody is quite good, 98% specificity. But if you're looking at an imperfect antibody assay with a disease that's less common than, let's say, MS, you're going to get false positives. And again, when we looked at the assay at the Mayo Clinic over 2 years, we found a positive predictive value of 72%. So at these low titers, it was actually only batting at about 50%. So again, you've got one of these low titer MOG antibodies. You want to have one of these features to make you think, yes, this is MOGAD. So that's the disc edema is very helpful, bilateral, that perineural enhancement on MRI. All those features will make you much more confident this is MOGAD optic neuritis at these low titers of MOG antibodies. Or if they're negative in the serum and only positive in the CSF, again, you need one of these kind of key characteristics of MOGAD optic neuritis. All right, let's talk about vision loss from optic neuritis. Of course, that's important. MOGAD tends to present with severe vision loss. As you can see here, in a cohort of 242 patients, MOGAD at nadir presented with a vision of 2400, so that's worse than legally blind. Pretty similar to our Aquaporn 4 NMOSD cohort, which presented with count fingers. Again, much better than the classic MS optic neuritis, which median nadir of 2070. So MOGAD presents with severe vision loss. Fortunately, despite presenting with very bad vision, they tend to recover, especially with steroid treatment. You can see here that the median visual acuity was 20/20, with only 5% of patients ending up 2200 or worse, which actually looked very similar to what we saw in the ONTT and MS, where only 3% of patients ended up 2200 or worse, and much better than what we see in NMOSD, where typically most studies show over a third of patients end up 2200 or worse. So again, MOGAD presents with severe vision loss, very similar to NMOSD, but fortunately have much better recovery, leading to much better outcomes. It's important that even though the MOGAD presents with severe vision loss, NMOSD presents with severe vision loss, there's overlap. You can see here that, again, the majority of NMOSD and MOGAD are presenting with that severe vision loss. But even NMOSD and MOGAD can present with more mild vision loss. So just because you've got a patient who presents with 20/40 optic neuritis, that doesn't exclude the possibility that this is NMO, doesn't exclude the possibility that this is MOGAD. It makes it less likely and more likely to be, MS and your typical optic neuritis, but it doesn't exclude that possibility, and that's important. We had recently did a study where we actually had a lot of details on 140 MOGAD attacks. Again, we've got large cohorts of MOGAD, but in terms of details, a lot of details. We had a international retrospective study where we looked at 140 MOGAD attacks. And what we found is, on average, that patients had eye pain for actually 3 days before the vision loss started. And overall, 89% of the cohort had eye pain. After, on average, 3 days of vision loss, and again, actually 80% of patients actually had pain that started at least a day before the vision loss even started, almost like a warning sign. After the pain, on average, the vision dropped for 4 days before reaching a nadir of 2600 in this cohort of 140 patients. And then over anywhere between some patients as early as 5 days, some as 90 days, the majority of patients recovered, with only 13% remaining worse than 20/40 and only 5% ending up 2200 or worse. So again, that majority of patients recover. And so this is the time course that we expect for our patients. So again, in terms of vision loss, severe vision loss at onset, but typically good recovery with only 5% ending up 2200 or worse. So now we're going to focus in a little bit on OCT. We always hear about eyes are the window to the soul, but OCT can also be the window to the brain. So we looked at this picture again, this OCT of my own eye, and we talked about how RNFL is helpful in the acute setting because see RNFL thickening, but it's also helpful because over time, the RNFL and ganglion cell tends to thin after optic neuritis. And so it's a surrogate of optic nerve atrophy. And actually, some studies have shown, at least in MS, the brain atrophies over time that correlates to RNFL and ganglion cell layer thinning. And so this OCT is a way of analyzing the optic nerve and potentially the brain as well. And so this is just a patient with acute optic neuritis in the left eye and from MOGAD. And you can see again that profound RNFL thickening during the acute attack. In the acute attack, the ganglion cells are normal. And then over time, these thin. And so this is OCT after, a year after the attack. You could see that now there's RNFL thinning and some pretty profound ganglion cell layer thinning. And that's classic for any optic neuritis, including MOGAD. And so the question is there a difference between MOGAD and MS and NMOSD in terms of OCT thinning after optic neuritis? And what you can see here is that MOGAD causes, this is just a retrospective analysis from the Hopkins group looking at multiple studies. And what you can see here is that if there's no difference from MS, all these studies would be kind of lining up right here at the 0. And what you can see here is that MOGAD tends to cause more severe thinning of the retinal nerve fiber layer and the ganglion cell than MS. And when they looked at NMOSD, you can see that the numbers are much closer to that 0. They're kind of stratified there at the 0 mark. So what it means is that MOGAD and NMOSD cause similar thinning, severe thinning of the retinal nerve fiber and ganglion cell, despite MOGAD having much better outcomes. In MS, there was a very pivotal study coming from Hopkins where they actually showed that OCT thinning over time actually mirrored the brain atrophy in multiple sclerosis. And so the question was there analogous finding in MOGAD where you're going to see thinning over time that might allow us to monitor brain activity in MOGAD? And so this was a large study involving some centers in the US, including Mayo Clinic, Johns Hopkins, and then large centers in mostly in Europe, but and others as well, led by Friedrich Ertel in Germany. And essentially what the group found is that in MOGAD, there is thinning of the retinal nerve fiber and ganglion cell over time. You can see here in red, there's this mild, slow decline in the thickness. But what's also important is that we had healthy controls that we could compare it to, and that's shown in black. And you can see that we all, healthy controls, essentially all of us, even sitting here, our retinal nerve fiber layer and our ganglion cell layer is thinning over time. That's just the natural history of our optic nerve. And so you can see here that it thins over time, and you can see the slopes of these lines are very, very similar. And really, we found no difference in the thinning between MOGAD and controls. What it shows is there's unlikely subclinical disease in MOGAD. Again, very different than multiple sclerosis, where we do see that slow decline that mirrors the atrophy of the brain. With MOGAD, we don't see that. And so that's important. And then, so again, these are the characteristics of MOGAD. And now we'll just end briefly on treatment. So for treatment, it's interesting. There's been several studies suggesting that early steroid treatment is associated with better outcomes. And I just wanted to focus in a little bit on our study looking at 140 MOGAD optic neuritis attacks. We talked about how, again, on average, there's 3 days of eye pain. On average, there's 4 days of vision loss before reaching this nadir of 2600 and then recovery. We looked at the influence of steroids, and what we found is that in patients treated within 2 days of vision loss, 98% of patients ended up 20/40 or better, which is very good. compared to 83% of patients who were treated after 2 days. What was even more striking is that those treated within 2 days had a much less severe optic neuritis at nadir at the time of the steroid treatment than those treated later. You could see 20/60 versus count fingers. So I think a large part of this early steroid treatment that may be helping is that we're catching patients around right here before they don't get to their natural nadir of 2600 count fingers vision. If you catch them within 2 days, you're catching them at about 2060, 2040. It's a lot easier to climb back up that mountain when you're at 2060 than when you drop to your natural nadir of count fingers or 2600. It's kind of harder to climb that steep mountain, and you may not get back to 2020. Whereas you have early treatment within what we found 2 to 3 days, it might be easier to get back to 2020. And that's why we think that early steroids may be helpful in our MOGAD patients. And so in terms of our treatment algorithm, when you have a patient with MOGAD optic neuritis, we treat them with IV methylprednisolone for 5 days, followed by an oral prednisone taper over usually about a month. We've been starting to shorten our oral prednisone taper because, again, sometimes these MOGAD attacks are not only steroid responsive, but steroid dependent. So we do usually about a 1-month taper. We think that early treatment may lead to better outcomes. Again, this is a retrospective study, and so prospective trials are required. But it does make sense that if we're catching them early before they get to their natural nadir, it may actually prevent them, may allow for better outcomes. But it's important to note that spontaneous improvement can occur, even without steroid treatment. And then we want to consider plasma exchange if the vision loss is severe and there's no recovery after high-dose corticosteroids. We recently looked at a large multi-center, this was an international multi-center study of 395 optic neuritis attacks treated with plasma exchange. And again, this included groups in France, Germany, really all around the world. And essentially, we had 100 NMOSD patients, about 100 MOGAD, 100 MS, and close to 100 idiopathic. And we looked at the outcomes. The visual acuity at the time of plasma exchange was quite severe as expected because we usually use plasma exchange for severe optic neuritis. So the median visual acuity was count fingers. And the majority of patients recovered, median final visual acuity of 20/25. 43% recovered at 20/20. 2/3 were 20/40 or better, but 20% ended up 2200 or worse. When we stratified that by etiology, what you can see here is that MOGAD had significantly better outcomes, which is shown here in red, than NMOSD, MS, and idiopathic. And so in patients with MOGAD optic neuritis who don't respond to IV steroids, we think that plasma exchange could be a very good potential rescue treatment, as you can see with this strikingly good outcome with MOGAD optic neuritis. Another thing that we noted, and many other groups have noted, is that the time to plasma exchange probably does influence outcomes. You can see here that patients treated with plasma exchange within a week in green had a much higher chance of complete recovery compared to patients treated later, where this percentage drops to about 20%. Here you're sitting at about 65%. So early plasma exchange may be associated with better outcomes. Again, this is a retrospective study where only severe bouts of optic neuritis, sometimes unresponsive corticosteroids, are getting treated with plasma exchange. But again, it does suggest that early plasma exchange leads to better outcomes, where time is vision. And so again, our acute treatments for these various etiologies are very different. From the ONTT, we know that with MS optic neuritis, IV corticosteroids quickens recovery, but doesn't actually change the ultimate outcome. We know that NMOSD has very severe outcomes, very poor outcomes, severe optic neuritis. So patients should be treated with IV corticosteroids and plasma exchange. And with MOGAD, the acute treatment, I think early IV steroids is important. And we could consider PLEX, plasma exchange, if there's no response to IV corticosteroids. But most patients, MOGAD optic neuritis, do not need plasma exchange, probably about 10%. The chronic treatments, of course, are very different as well. MS is going to require your MS disease modifying therapy. NMOSD, all patients require chronic immunotherapy, the classic ones being rituximab, enablizumab, satralizumab, and eculizumab, the monoclonal antibodies. And then with MOGAD, it's very different because only 50% of patients with MOGAD are going to relapse. Only patients with chronic relapsing disease are going to need chronic immunotherapy. And in terms of options for treatments in relapsing MOGAD, We've got our classic old medications we use for NMOSD, like rituximab, azathioprine, or mycophenolate. But probably the more effective treatments in MOGAD are IVIG and tocilizumab. And I know you heard a lot of talks on MOGAD, so I don't need to get into that. But again, our chronic approach to MOGAD is going to be very different from MS and NMOSD. And so really, this is a quick summary of our MOGAD optic neuritis that we've talked about for the last 25 minutes or so. Again, these are the features that make you want to think about MOGAD. Fortunately, again, they present with very severe vision loss, so can be scary at onset, but fortunately have typically good recovery, especially with steroids. OCT is very helpful in confirming an optic neuritis attack, but fortunately, there's not OCT thinning independent of optic neuritis attacks. And in terms of treatments, early steroids may lead to better outcomes. Certainly something that we try to do for our MOGAD patients. And I'm happy to answer any questions you might have.
Chen, there is one question from the audience.
Congratulations for your great talk. I have a question about the asymmetry in the thickness in the acute phase. As 50% have bilateral optic neuritis, how did you deal with that? Even if it's bilateral, or did you check the delta to increase sensitivity to the previous increase?
That's a very good point. So for the bilateral cases, we put them into the absolute thickness. So the N in the absolute thickness was a little bit larger than the acute swelling in terms of the change. So when we looked at the magnitude of the change in RNFL, we incorporated patients with unilateral optic neuritis. We used the contralateral eye as the control, or in patients who had a baseline OCT before the optic neuritis attack, we were able to use those patients. So in terms of the absolute RNFL thickness, we had 96 patients. But then when we looked at the magnitude of increase in RNFL thickness, we had a lower number, probably about 2/3 of that number or so. That's a very good point. But you can still use the magnitude of thickness. So you've got a patient and you don't know the baseline, and it's bilateral optic neuritis, and you've got a thickness of 200 microns. That's probably going to be your MOGAD optic neuritis.
Thank you, Professor Chen, on behalf of the SLCTRIMS.
Thank you.
I would like to invite Prof. Letizia Leocani, who needs no introduction to this audience, to deliver us a speech on utility of VEP and OCT in diagnosis and prognosis of demyelinating disorders.
Thank you very much for your kind introduction, and I thank the organizer for inviting me here, but also for putting together this very important session. I learned a lot from the first two speakers, and I take the occasion to congratulate with them. These are my disclosures, and I would like to share with you some thoughts related to the diagnosis and differential diagnosis of MS and demyelinating diseases. This is to honor Axel, who did a huge work on this diagnosis and classification of optic neuritis. And so I will skip all the clinical features of typical and non-typical optic neuritis and go straight into the tools that we have to assess demyelination and neurodegeneration in the optic nerve. And I also thank Dr. Chen for explaining OCT so nicely, so I can just focus on the visual evoked potentials that have the advantage of being quite easy to perform. Just one recording electrode referred to the vertex in the classical full field VEPs, which are quite old but still resist the advancement of technology. And they have the advantage of being also non-time consuming in 15 minutes you can do both eyes, but the disadvantage is that concerning the topography of the involvement of the optic nerve, they cannot tell you much because they are mostly based on the central vision. Although you stimulate the full visual field, the periphery of the visual field will cancel each other in the visual cortex because they are represented in opposite banks of the visual cortex, and so that what is left with the P100 is only what is originating in a very small 15 angle of the visual field. So only, although you stimulate the whole full eye, you only get a small portion of the sector, the central sector. While the multifocal VEPs have the disadvantage of being more expensive in terms of acquisition of the equipment, training of personnel, and time you have to invest in each single examination. So from 15 minutes of the full field, you go to like 40 minutes of these examinations. I would reserve this not only for research to define the features of the different demyelinating diseases, but also in case when in the clinical setting we're not satisfied with the full field VEPs, which are good as screening tool. The optical coherence tomography is offensive if I keep explaining. But I would like maybe to underline the fact that in the retinal nerve fiber layer thickness, we can also like unwrap the full disc and that we the full disc scan, and so have different sectors of the circle. And I would like to underline the important part that is important for MS, which is the connection between the macula and the optic nerve, which is the papillomacular bundle, which is in the temporal region. And I think this is important to differentiate MS, MOGAD, and NMOSD, because in MS you have the pathology that starts from the center of the optic nerve, and that is also explaining why patients have central scotoma and why maybe they can do badly in letter reading, especially in the low contrast. And this is going to correspond to atrophy that could be very minor, but important, because a very small atrophy in a very small part of the retina is hitting the very most important part of our visual field, which is the central part that we use to perform when they test our vision. And so this could explain the dissociation between huge retinal nerve fiber layer loss in widespread diseases, but do not affect specifically the central field, like in NMOSD and MOGAD, mostly, and MS, where only a small part of the retina is affected, a small part of the optic nerve, but the most essential, so they don't perform maybe as well as MOGAD. And there is also an issue of time when we compare the two methods, because apart from the cases in MOGAD where there is quite often increase in thickness, the increase in thickness is not so helpful, and people did not look at so carefully as Professor Chen. So I think we have to go back in our old data and test the sensitivity of retinal nerve fiber layer abnormalities in the sense of going upwards and not back and downwards. But concerning atrophy, we need 3-6 months before the atrophy develops in any optic neuritis, because it takes time for the axons to degenerate from the site of the lesion to the retinal layer, while the VEPs are abnormal not even immediately after onset of symptoms, but I had a case where I found VEP delay 2 days before the onset of symptoms. So that is really adherent with the demyelination occurring in people with MS. That was an MS case. I cannot tell you about the timing of the respective delay in VEPs in the other two diseases. as we saw, there is a starting of pathology in the periphery of the optic nerve. So it could be that MRI can see enhancement before we see a VP delay in MOGAD. I don't know. We have to test. So John, think about it. We need your help. But concerning the VEP, that could be a disadvantage if we aim at using VEPs months after the optic neuritis, because there is remyelination. So remyelination is a physiological event, even though it occurs in a pathological condition. So a lack of abnormality of VEP, if you wait 3 months, 6 months before you perform VEP, is not a failure in the examination, is our own failure in performing VEP at the right time, which is within a week from the symptoms. If we do it late, VPs are not helpful, but not because of their limitation, but because the optic nerve is doing something while we wait for doing the testing, so it's not waiting for us. And so this is going to explain the dissociation between the sensitivity of VEP and OCT. And again, I have to admit, here we focused a lot in the asymmetries, in lowering of thickness, but not in the increase. So here the sensitivity could be higher. So I have to go back myself in the data. But the OCT sensitivity is much less, and we're talking about MS, in the acute phases, and it goes higher as you approach the 6 months typical target, and where it equals VEPs. But VEPs have, at this point, have recovered greatly. So if you go back in time, you can see that the sensitivity is 90% and not 60%. So the two sensitivities are equal if you wait a long time. So if you wait, you give an advantage to OCT and you give a disadvantage to VEP. We tend to do VEPs even in the emergency room, so that's why our sensitivity is high. And that's why there is variability in the sensitivity of VEPs across studies that tended to test the value of VEPs in the diagnosis of MS. That was, of course, before the new data that emerged, and of which also Professor Montalban talked about yesterday, about the new criteria. But studies like this one, where VEPs were performed within 1 year, don't play a good in favor of VEPs, because of course the sensitivity of VEP is going to be much lower than in this other study where the sensitivity was 96% and the study was performed within 3 months from the onset of symptoms. And also this first paper by Angela Vidal-Jordana from Montalban Group, where they first suggested that the VEPs do not lose specificity and increase the sensitivity in the detection of optic nerve involvement, was about 3-4 months after the onset of optic neuritis. So they were helpful in helping VEPs to get back the role they deserve, which is to assess demyelination in the acute phases. And also, if you wait 3-6 months, there would be a good correlation between the amount of axonal loss in MS and the amount of VP delay, meaning that the more demyelination you have, the more axonal loss. But actually, I put this paper from our group not because of the correlation. We will go back to the correlation later, but because of the fact that we should not forget the value of VPs in detecting subclinical abnormalities, which if you don't pay attention, and at that time we did not do, to asymmetries, is much higher in VEPs compared with OCT. I will show you later that if you consider the asymmetries that Professor Chen was talking about, the sensitivity can become similar. But of course, we have also to consider asymmetries for VEPs. But having a subclinical abnormality, as in our paper, in brain in 2021 is also important not only for the diagnosis but for prognosis, because subclinical abnormalities in the optic nerve are associated with greater disease burden, meaning higher number of lesions, for example, and so it could be possible that these could be used when choosing the first treatment to maybe push towards a more effective, more aggressive treatment. And going to the issue of the inter-eye difference that Professor Chen introduced when talking about the acute phases, that could be useful also in detecting subclinical abnormalities in the optic nerve and also in detecting all the optic neuritis episodes that were not leading to a diagnosis of MS because they were maybe neglected. And in this second work by Angela Vidal-Jordana, where they tested in the SEMCAT group the possibility of detecting subclinical abnormalities, here we can see that the sensitivity, if we consider asymmetries in OCT, is quite similar. So it's about 20% both in VEPs and OCT. So it could be nice to combine data to see whether we can increase the sensitivity of VEP by using a similar approach with the inter-eye asymmetries. And concerning the differential diagnosis, again, the combination of VEP and OCT can help because we know from the teaching of Professor Fujihara that MS is an anti-MOGAD are demyelinating diseases, while neuromyelitic optica is not. There is demyelination because, of course, if you kill all types of tissue in the optic nerve, starting from astrocytopathy, you have axonal loss and also demyelination. But in my mind, demyelination means having axons that lose their myelin, not losing myelin together with axons. That is, in that sense, also a stroke should be a demyelinating disease, because if you do histology in stroke, you see a loss of axons, you see a loss of myelin. So just a staining of myelin to show demyelination, I don't think is enough to bring the concept. The concept is preserved axons, living axons without myelin. That's my idea of demyelinating disease. So having said that, there were suggestions starting from Brazil and Japan that there is a greater degree of axonal loss that is almost equal in proportion with myelin if we consider NMO, with, especially compared with MS. And that was coming from VEPs, from the observation that they are more frequently absent in patients with NMOSD, or with decreased amplitude but not so much a delay, which is actually the opposite of the classical McDonald observation that in typical MS you don't have a big amplitude reduction, but you have a big delay. So here we see the opposite. And also there are lots of huge number of publications showing that there is a big loss in axons in NMOSD, but that the loss is quite widespread while it is involving the papillomacular bundle in MS. Again, the topography is also different, but just considering the thickness, again, if we compare the thickness reduction in NMOSD, that is almost always below 60 microns, at least with the Heidelberg device, but of course we can find a similar cutoff with other diseases, other devices, but in MS with optic neuritis, this is rarely the case, even if we wait over 6 months. And so there is a big difference in the amount of axonal loss. And concerning the delay, there is quite an opposite situation, because almost never you can see a delay of over 150 milliseconds in NMOSD. That is really quite exceptional, while it is quite frequent to finding in not only after optic neuritis in MS, but also in subclinical optic neuritis. So this is, I think, making a big difference, because in NMOSD, you cannot lose myelin without losing axons. Actually, myelin is lost because the axons are just destroyed. So, and in MS, you have demyelinated axons that are still alive, so they can give you a brain cortical response, but they're very slow. So the response they give you is very, very delayed. And so by combining the deviation from the norm in MS and the deviation from the norm in NMOSD, but by combining the two deviations, how much delay there is and how much axonal loss there is, you can separate the two entities. So a big imbalance towards delayed VP and a big imbalance towards reduced axons. So that's a good separation in my view, and that's why maybe OCT can be complemented with VEPs, and maybe at different times. Baseline VEP and 6 months OCT. Of course, the acute OCT now is becoming very important after listening to Professor Chen. I cannot say anything about MOGAD after what I heard by Professor Chen, but I would like to remind you the topography that was maybe less stressed in that talk, but he stressed a lot the imaging that was involving the peripheral portions of the optic nerve, and by pain that is preceding visual loss in MOGAD. So these two features, in my view, help me to consider periphery to center involvement in MOGAD and the center to periphery involvement in MS. And that could explain the different topography of OCT, but maybe also the dissociation between OCT atrophy that you find in MOGAD that could be very severe, because please remember also that the peripheral axons are the largest. So losing peripheral axons is giving you a huge delta in retinal nerve fiber layer because you lose big axons, while the small axons lost in MS are the small ones, so they don't contribute a lot in percentage reduction in retinal nerve fiber layers, but they are the ones we need to perform when the doctor is testing our vision, because they don't ask us to see peripheral objects in our field, but they ask to read letters. So this is going to be important. And concerning the prognosis, again, the prognosis maybe comes from, depends on the diagnosis. So I would like to just mention the first work on prognosis that was not about prognosis after optic neuritis, but prognosis concerning the course of the disease of a simple OCT independent of optic neuritis. So even without optic neuritis, having a lower axonal reserve is predicting of disability worsening after 2 years. So I would like to acknowledge the first multi-center big study by Elena Martinez-La Piscina. But if we're talking about optic neuritis, if we're dealing with MS, a big VP delay is prognostic because in people with MS, having early on a very large degree of delay in VPs, more than 140 milliseconds, is predictive of a lower axonal loss, a lower axonal layer thickness at follow-up after 6 months and 9 months. And this is mostly true in people over 33 years, meaning that the mechanisms of recovery and neuroprotection are more active in younger people, so that a big delay is not necessarily accompanied by a big axonal loss, while this is the case if you're over 33. And again, the prognosis depends on the diagnosis, because if we go to MOGAD, having a big visual deficit at baseline or bilateral means that your optic neuritis is suggestive of MOGAD and not of MS. So having bilateral loss together with optic disc swelling actually is suggestive of MOGAD, and so the prognosis concerning visual function is better. And so this is why, for example, in this study in China, having a higher having disc swelling was associated with better visual acuity, which of course is the opposite if we consider people with MS, where a severe edema at baseline is predictive of a future more severe axonal loss. And I would like to mention the issue that optic disc swelling could be associated not only with edema, which may explain big visual loss at baseline, not necessarily accompanied by persistent visual loss, because once the edema resolves, the axonal block can resolve as well, and so lead to a good recovery. But if the axonal, if the edema is very severe, it could lead to vascular hypoperfusion, and it has been demonstrated that more severe axonal loss can be observed in cases of more severe swelling. So I would like also to ask in the future Dr. Chen whether he can find a similar association in eyes with unilateral optic neuritis, where of course we can have a proxy of the baseline thickness by using the healthy eye. So maybe we have more reasons for having axonal loss after an acute episode. So one could be the axonal damage acutely by the attack itself, but another mechanism could be secondary ischemia due to swelling. About the monitoring in the long term, I really enjoyed the slide by Professor Chen showing that there is not so much longitudinal thinning in MOGAD, which is different from what we find in MS. In MS, in this work, we compared people with evidence of disease activity and no evidence of disease activity. And we focused on the group with evidence of disease activity. So our main message in this paper was that the evidence of disease activity in people with MS is accompanied by a larger loss in the retinal axons, although in no patients in this group there was an optic neuritis that helped us classifying patients as with evidence of disease activity, meaning that in these patients there was a decline in retinal nerve fiber layer thickness, but not because of optic neuritis, because of lesions elsewhere. But we did not notice that also the group with no evidence of disease activity has a reduction in retinal nerve fiber layer over time. And actually, in this second paper, we focus on what happens in people with no evidence of disease activity. And we found that we enlarged our focus, our lens, on this group. And so we found that actually this little change was clearly different from the no change that we have in NMOSD with no evidence of disease activity. So we can say that in NMOSD, the reduction in the thickness is related to attacks, even if they are remote from the eye, while even in people with no evidence of disease activity, if they have MS, there is a subclinical degeneration, even if the MRI is stable, no atrophy, no EDSS worsening. And I have to say, in this pathological work that Marco Pisa, the same author, did in Oxford, with Gabriele De Luca, he found that there is activity, there is inflammation in both diseases, in MS and in NMOSD, but there is a sign of demyelination and remyelination only in the group of people with MS, and no demyelination with evidence of remyelination following demyelination is evident in NMOSD. So this is the only example that can show improvement. So OCT can normally show only a reduction in the thickness in the chronic monitoring, while the VP have the advantage of being able to show improvements that could be suggestive of remyelination. So I hope I gave you an overview of how we can use VEPs that maybe are rejuvenating lately in these years, because their major value is to give additional information on the time of lesion and on recovery after optic neuritis. Thank you so much.
Thank you, Professor Leocani. Are there any questions for the speaker? Professor Leocani, you said the visual evoke potential comes to normal after 3 months, so in MS. So in MS we know that is a demyelinating disease, but NMOSD is based on axonal loss. So do you see a difference in recovery of PEP in between these two diseases?
This is a very good question, but unfortunately, the study with detailed timings that we have is in people with MS, while in MOSD we had more variable assessments, so we did not have the hyperacute assessment, so we could not give you this information. But we can say that the recovery can be considered full in about 30–40% of cases in case of VEPs after optic neuritis in MS. And so that would be a big loss if we waste time in our assessment. But thank you, this is something worth checking.
Thank you. So next we are awaiting a special segment. So I would like to invite Dr. Arun to announce the Young Investigator of ECF-SCLTRIMS Award. Dr. Arun.
Ladies and gentlemen, we have arrived at the awarding of the prestigious European Charcot Foundation SLCTRIMS Young Investigators Award for the recognition of an exceptional researcher under the age of 35 years. This award, introduced for the first time this year, is a result of years of collaboration between Europe and Sri Lanka and entitles the awardee with membership to the coveted European Charcot Foundation's fellowship community, along with a fully funded invitation to the annual meeting of the ECF. A joint jury with representatives from the ECF and SLCTRIMS shortlisted the following outstanding candidates for this award: Dr. Udari Samarasiri, Dr. Maithili Aravindan, Dr. Shanindra D. Alvis, and Dr. Devasmita Vijayasundara. And following intense deliberation, the jury reached an unanimous decision to present the inaugural ECF-SCLTRIMS Young Investigators Award to Dr. Maithili Aravindan. Dr. Maithili Aravindan is currently a senior registrar at the Professorial Unit in Medicine of the National Hospital of Sri Lanka and a lecturer at Department of Clinical Medicine, Faculty of Medicine, University of Colombo. I would now like to call upon Professor Giancarlo Comi, President of the ECF, to present the award to Dr. Aravindan.
It is really a great honor for me to award Maiteli for the beautiful piece of research you have done. The winner of this award is joining the community of the young investigator at the European Charcot Foundation. Is a community of about 70 people. All are winners of the award in different parts of in different continents. So you are really part of this new community. I have to congratulate you.
Now we have come to the final segment of this year's Congress. So this is on case discussion, is on 5 interesting cases to be presented by our young trainee neurologists. Unfortunately, our co-chair, Piara, had to leave early, so both of us will be chairing the session, Arjun and me. So I think we'll straight away, the rules are that you will have to present your case in 8 minutes, and the foreign faculty will be asked to discuss the case. So the first case is to be presented by Dr. Dilini Chandrasiri.
Good afternoon. So this patient is a 53-year-old male, a doctor with diabetes mellitus. He first presented to us in April 2023 when he developed gradual onset progressive left-sided hemiparesis and slurring of speech over 2 days. This was preceded by a febrile illness 1 week before, but he denied any headaches, seizures, altered level of consciousness. Examination revealed left-sided spastic hemiparesis with left upper motor type facial nerve palsy with normal cerebellar examination and yes. So the CSF studies, there was normal glucose with no significant sugar drop, but there was a cellular reaction with lymphocytic predominance. CSF oligoclonal glands were negative, TB gene expert culture were negative. This is the MRI brain with contrast. There were multiple space-occupying lesions. The largest was in the right thalamus, measuring 1.4 into 1.4 centimeters. And also there was a lesion found in right cerebral peduncle of the midbrain, involving the tectum also. These lesions were T2 flare high signal lesions, which showed mild expansion with predominantly peripheral diffusion restriction and avid contrast enhancement. And similar lesions were found in the splenium of the corpus callosum and subcortical region of the right temporal lobe. In addition to that, there were 2 areas of gliosis and volume loss with old infarcts in the bilateral frontal lobes. So, a diagnosis of central nervous system inflammatory demyelinating disease was suspected, possibly a ADEM-like illness, although there was no clinical or electrophysiological evidence of an overt encephalopathy. However, the patient was pulsed with 5 doses of IV methylprednisolone, followed by oral prednisolone, to which he showed a dramatic improvement. And he was discharged on oral prednisolone, and it was planned to repeat the MRI after 8 weeks. So the patient was readmitted in 2 months' time for follow-up MRI brain. But on admission, we noticed that the patient was having left-sided hemiparesis, which is of new onset again. And over the next 2 days, it progressed into a dense left hemiparesis, and he was drowsy and there was slurring of speech also. So this is the repeat MRI brain with contrast. The previously noted lesions in the splenium and the subcortical region of right temporal lobes were not there, but there were multiple new lesions appearing with perilesional edema in both cerebral hemispheres, pairing the cerebellum and the brainstem. The largest lesion measured 4.2 into 2.9 into 2.5 centimeters in size. It was located in right parasagittal frontal lobe. There was mass effect, and it showed peripheral contrast enhancement with central non-enhancing areas. And there were similar 2 lesions which measured 3 into 3 centimeters with again contrast enhancement in the adjacent right frontal lobe inferior to the largest lesion, and multiple similar small lesions were noted in the left inferior frontal lobe and left centrum semiovale. So the appearances were more in favor of demyelinating illness. That was what the formal radiological reporting said. This is the MRS of the patient. There was a choline peak with increased choline to Na ratio, but it did not help us a lot in differentiating between demyelination and a neoplastic process. This is the repeat CSF. Again, there was no protein elevation. There was a lymphocytic pleocytosis. Anti-aquaporin 4 antibodies, anti-MOG antibodies, and anti-neuronal antibody panel were negative. So he was again started on IV methylprednisolone, but this time there was almost no response at all to steroids. So the possibility of central nervous system neoplasm was considered, and a brain biopsy was planned. In the meantime, to give the benefit of doubt to the patient, we planned to proceed with therapeutic plasma exchange. However, it got delayed since the patient developed a hospital-acquired pneumonia and went into sepsis. So, however, we could proceed with brain biopsy, and brain biopsy confirmed heavy inflammatory cell infiltrate with predominant histiocytic reaction with mild perivascular lymphocytic infiltrates, and there was no evidence of necrosis or atypical lymphoid cells. So it was suggestive of an inflammatory process rather than a neoplastic process. So a diagnosis of possible tumefactive multiple sclerosis was made, and the patient underwent therapeutic plasma exchange and rehabilitation, and he showed a significant improvement in the limb power. And then subsequently he was started on intravenous rituximab therapy. The patient improved clinically also, and the follow-up MRI brain after 6 weeks showed a remarkable improvement of the radiological lesions, and clinically also patient was much better, and patient is back at work now. So my questions are the diagnosis of tumefactive lesions in MRI and the differentiating among different underlying etiologies, for example, tumefactive MS, true neoplasms, MOGAD. So there are multiple diagnoses that can be considered when we see a tumefactive lesion in MRI. So how can we differentiate among them without going for a brain biopsy? And what is the expected course of disease, and how will the patient be monitored over the long term, and what should be the long-term management of this patient, and how is it different from that of a patient with typical multiple sclerosis?
Yeah, thank you, Dilini. Actually, so there are quite a few questions here. The initial response to steroids, then subsequently he did not respond to steroids. So that is one thing. And about the diagnosis, all the antibody panels were negative. So there was nothing to suggest on that. And of course, the radiology was reported mostly as inflammation, possible inflammation. Then the biopsy showing inflammation rather than malignancy. And of course, he responded finally to immunotherapy, and he's back at work. Actually, he's a medical doctor.
Can I start to comment? Well, it is easy to say what is not. It is almost impossible, at least from my knowledge, to say what it is. It is not MS for sure. That's not. What was curious was that the disappearance of the initial lesions. If I understood what you said, the initial lesions disappear when there was a second attack, which is a bit very, uncommon, except that in MOGAD, because when I listened, I said, this is a MOGAD. But then the test was negative. So I was wondering if the MOGAD was also tested in the CSF, because this type of behavior with waves of large lesions in the brain, homogeneous lesions, it is really suggestive of a MOGAD condition, but Professor Fujiwara is much more expert of me, so I would like to listen to your opinion now.
Yeah, well, thank you, Giancarlo. Yes, I also think this is not a typical MS, although it is a relapsing disease. And so Giancarlo already mentioned that some MOGAD cases may have CSF-restricted MOGA IgG and seronegative. So I also think that CSF should be tested for MOGA IgG in this case. And by the way, for detecting MOGA IgG, did you use Euroimmune's fixed cell-based assay? Which method do you think did you use to?
It was cell-based assay, sir. I'm not sure whether it was fixed cell-based assay, to be honest.
Okay. And as for the lesions in the first event, although it seems they did not disappear at all, but they shrunk very much significantly, that may be consistent with the findings seen in MOGAD. So I also think that you had better test CSF, because in our own experience, some patients with brain lesions or spinal cord lesions may have CSF-restricted MOGA IgG. On the other hand, if your patient has isolated optic neuritis without any brain or spinal cord lesions, usually you have only to test serum. And as for the probability of detecting CSF-restricted MOGA IgG, the probability is the highest in patients with cerebral cortical encephalitis that we reported in 2017. So again, I agree with Giancarlo that this is not what typical MS, although it is a relapsing disease. I also suggest to test the CSF for MOGA IgG. So that's my suggestion. Thank you.
Can I just, if it is MOGAD, what's the phenotype you're thinking of, Kasu? Is it like ADEM kind of phenotype? Because he was not encephalitic.
Well, ADEM-like phenotypes. So one of the 6 core clinical demyelinating events is monofocal or polyfocal cerebral deficits. So this case may correspond to that. As you mentioned, this patient did not develop encephalopathy. So based on the diagnostic criteria, this patient may not be diagnosed with typical ADM. So,
thank you very much. Thank you. So we move on to the second case. Dr. Pumi Hettiarachchi will be doing.
Thank you. So my patient is 16-year-old boy who presented with gradual onset, progressive bilateral and upper limb, lower limb weakness and simultaneous bilateral visual impairment for 2 months duration. So this is the timeline of event. Initially in October 2023, he has developed bilateral feet numbness, which was gradual onset and symmetrical. The numbness was gradually ascended upward with associated bilateral fingertip numbness as well. At the same time, he has developed bilateral simultaneous visual impairment, which was painless without color desaturation. And 1 month later, that is in early November, he has developed bilateral lower limb weakness, which was progressive over the next few weeks. With that, he has had progressive ataxia and gait unsteadiness as well. So on examination, there was reduction in bilateral visual acuity, with the right visual acuity being 6/18 and the left of 6/12, without any RAPD, and the fundi, there was bilateral temporal pallor. Other cranials were normal, there were no cerebellar signs. And there was spastic quadriparesis with predominant involvement in the lower limbs, with absent ankle jerks and downgoing plantar. The sensation was impaired up to bilateral mid-calf level with impaired JPs in the lower limbs. So with those findings, we thought of myeloradiculopathy or myeloneuropathy with optic nerve involvement, and we went ahead with investigation. So CSF studies done at 7 weeks, approximately 7 weeks into the onset, was completely normal. Then we repeated CSF studies in about 9 weeks' time from the onset that has shown increased protein without any cellular reaction. However, we couldn't go ahead with CSF of OCB due to financial problems. So this is the imaging, and MRI brain was normal. The MRI orbits has shown high T2 signal intensities in anterior optic nerves with mild contrast enhancement. The MRI spine with contrast has shown the high T2 signal intensities extending from C3 to D8, predominantly involving the posterior cord, with some patchy anterior as well as the lateral cord involvement. That is mainly the peripheral involvement without any contrast enhancement. So the optic nerves were contrast enhancing, but the spinal cord lesion was not contrast enhancing. However, there was thickening and enhancement of the lumbar roots were there. So we went ahead with the nerve conduction and EMG that has shown absent and reduced mode amplitude with normal velocities and latencies. The sensory responses were normal and the F waves were abnormal. There were subacute neurogenic changes in limb EMG. The conclusion was these findings were mostly consistent with diffuse radiculomyelopathic pathology considering the clinical picture. So OCT has shown bilateral temporal thinning, and there was diffuse ganglion cell atrophy, which is asymmetrical, right more than left. And in macula, there was bilateral perifoveal atrophy. The VEP has shown that right-sided pattern VEP was not recordable, while the left response is significantly delayed with the P100 of 143. And the pattern ERG was normal. So we went ahead with AQP4 antibodies and MOG antibodies, both were negative, and anti-nuclear antibody testing were also negative. including the basic blood investigations, all those things are normal. So we came into a tentative diagnosis of seronegative NMOSD, and initially he was treated with intravenous immunoglobulin, but there was no improvement. Then he was started on methylprednisolone pulse therapy, for which he didn't improve. Then we went ahead with plasmapheresis 5 cycle, for which his vision as well as the limb weakness improved subjective. There was subjective as well as objective improvement. So we started him on IV rituximab as well. First dose was given, and then he was discharged with oral prednisolone, azathioprine, and it was planned to give second dose of rituximab in 2 weeks' time. So recently, about few days back, he readmitted for the second dose of rituximab. On admission, he complained, he was noted to have blurring of vision, which was bilateral and painless. But there was no worsening of limb weakness or appearance of limb numbness. So he was again started on intravenous methylprednisolone, and we have already planned to give rituximab second dose. So these are my discussion points. This is a patient with bilateral simultaneous optic neuritis with acute longitudinal extensive transverse myelitis and radiculitis with MRI evidence. However, these MRI evidence, these are a bit atypical and mainly anterior bilateral optic neuritis with some contrast enhancement that the myelitis was not contrast enhancing, there was enhancing radiculitis. And the serology was negative, double negative serology. So is this a case of seronegative NMOSD with radiculitis, or else a demyelinating mimic? So what are the MRI findings in seronegative NMOSD? What is the expected course of the disease and the long-term monitoring if it is a seronegative case of seronegative NMOSD? And the long-term management of patient and how is it different from that of a patient with seropositive NMOSD?
Is it on? Yeah. So some of my observations are, this is a young boy who developed a very subacute progressive disease, and overall the progression and the nature in which it evolved does not suggest a demyelinating pathology. That's the first thing I thought. And he appeared to have a progressive neuropathy-like pattern in the sense that he had sensory disturbance up to the knee when he developed numbness in the hand, though your nerve conductions are not suggesting a peripheral sensory etiology. So with the prolonged FA latency, it's possible it is a radiculopathy associated with a myelopathy. So when you look at the MRI, the posterior column involvement very selectively leads me to the conclusion that there may be a myeloradiculopathy or a myeloneuropathy involving spinal cord and the cranial neuropathies, and the obvious things you would like to exclude are nutritional deficiencies, like for example vitamin B12 is what came to my mind initially, and toxic environmental associations could be looked at, viral associations and history of any opportunistic infection in the background, for example, a hepatitis B or a C infection or an HIV-related infection. Those are things that would produce this combination in this kind of a subacute progressive way. I would not have thought of, and then HTLV1, I don't know whether it is common and whether it's, maybe it's a little too quick to develop the rate of progression. But non-compressive myeloradiculopathy, yes, but not demyelinating. I think we need more investigations.
Okay, madam. We also have suspected vitamin B12 deficiency initially, and in fact we treated with B12 as well. So the serum B12 levels were normal, and including the serum homocysteine as well as the methylmalonic acid levels. So there was no evidence of B12 deficiency, and the hepatitis B, C screening was also negative. So,
I have a question to you. Why you are speaking of radiculitis? Because I would like to see EMG examination that demonstrate a decrease of the amplitude of sensory potentials. Otherwise, I think that all the sensory and motor problems can be explained by just the myelopathy without asking for radiculitis. Usually, if you have a radiculitis, you can expect to see some enhancement of the roots, which is not there. There was no enhancement of anything. The second point is because there are many data, but I think that the second CSF examination revealed a quite high level of proteins. Again, that's a bit in contrast with a problem of, vitamin B12 deficiency or other deficiency, because this very high level is indicating of a quite clear damage. And again, even if we don't see any enhancement, it's highly suggestive of an inflammatory process. And that's to me a very important aspect. Just based on the data, I think we are more in the direction of a seronegative NMOSD.
Thank you for presenting the very interesting and difficult case. And as for the diagnosis of seronegative NMOSD, as far as I remember, the optic nerve lesions are not so long, not longer than half of the entire optic nerve length, and the spinal cord lesions seems to be a very patchy. Is it contiguous?
Yeah, it was a short segment of anterior optic nerves were involved.
So those findings may not fulfill the current 2015 diagnostic criteria of seronegative NMOSD. Am I wrong?
Yeah. They have not given actually that length of the optic nerve involvement not included in seronegative diagnostic NMOSD diagnostic criteria, sir.
Okay. And by the way, so as for the aquaporin 4 IgG positive NMOSD with radiculitis, we previously reported 2 cases with pathological findings, and actually the small proximal portion of radicules are actually expressing AQP4. That may be why occasionally, but only rarely, those patients did have mild radiculitis, and it was proven by the pathological findings. That was an autopsy case, but this case may be different. But those are my comments. Thank you.
Thank you. Thank you.
Bim. Yeah. In the first case, I forgot to mention that I was not quite sure what kind of demyelinating pattern was seen. I mentioned the neuropathological findings of MOGAD, but I was not quite sure if those findings were seen in the biopsy, the samples. I guess the large frontal subcortical lesions were biopsied, but
No, I don't think they were. I can't remember the pathology.
No, it just showed the perivascular lymphocytic infiltrations in the first one, not suggestive of a lymphoma.
But how about the demyelination pattern? Was it consistent with perivenous demyelination that I mentioned yesterday in my talk?
No, I don't think.
Not done. Yeah, so please analyze the biopsy, the specimens further. Yeah.
Thank you, Dr. Pusjara. We move on to the next interesting case to be presented by Dr. Chapa Ranasinghe.
Good afternoon, everyone. So I'm going to present another case. This patient is a 21-year-old boy who is with the diagnosis of epilepsy since 2013, but he was not on regular follow-up and was not on anti-seizure medication by the time he presented to us. He presented with headache, fever and vomiting and confusion. This happened in May 2023. And after admission, he developed 1 episode of generalized tonic-clonic seizure and 2 episodes of left focal tonic-clonic seizures. So with this, we did MRI brain. This is the T2 FLAIR images, which are showing right temporal cortical enhancement with effacement of sulci, and also then T1 contrast, and there was there was no contrast enhancement, and mild cortical brightness in the diffusion was DWI images only. So with this, we further inquired into his past medical history, where he came up with a history. In 2013, when he was 11 years of age, he developed 1 episode of right-sided partial tonic-clonic seizures. And following that, he has had right-sided upper limb weakness, which improved over 2 to 3 days. And he was started on anti-seizure medications, but after about 1 year, he has defaulted. Then 2 years later, in 2015, he developed left eye visual blurring, which was investigated in a tertiary care center, including brain imaging and CSF analysis. And that time, there has been a suspicion of a CNS neoplasm and planned for brain biopsy. But he was not much disturbed with visual impairment because he could engage in day-to-day activities, and visual acuity apparently has not been very severe, very impaired. So again, he has defaulted. Then for the next 5 years, he has been asymptomatic without any visual symptoms or any seizures. In 2020, that means 5 years after the visual blurring, he developed again right-sided tonic-clonic seizures, this time without fever, headache or confusion. And then MRI brain was performed. Again, you will see there is left parietal lesions with cortical swelling enhancement and effacement of sulci with some contrast enhancement in the gyri. So this time again suspicion of with MRS findings, also suspicion of low-grade CNS glioma was there, and he was actually managed in a neurosurgical unit because of this, and that time planned for a repeat MRI brain before going ahead with biopsy, which has happened in 6 months' time, showing the resolving lesions. So again, patient was asymptomatic, and so there has been no regular follow-up after that. So now coming back to the presentation to us with again seizures with encephalopathy and fever. So with the given background history, we did further investigations including CSF analysis. Protein was normal, but there was a lymphocytic reaction, and with the temporal lobe involvement in the MRI, we did HSV PCR, which came as negative, and at that time he could not afford to do NMDA receptor antibodies. And EEG, there was focal slowing in the right temporal leads. And however, with the suspicion of autoimmune encephalitis, we gave IV methylprednisolone, for which he had a remarkable improvement. So even though he did not complain of any visual symptoms at the presentation to us, because there was a background history of visual blurring in the left eye, we did ophthalmological evaluation. Visual acuity was normal with impaired color vision more on the left side, and visual fields were normal. However, fundus showed mild pallor in the bilaterally. VEP was not recordable in the left side. In the right side, it was significantly delayed with 148 milliseconds. And then we went ahead with OCT, which showed significant ganglion cell loss, and then retinal nerve fiber layer at optic nerve head was showing significant atrophy more on the left side, sparing nasal fibers. So with this, and we did further serological investigations, which included MOG antibodies, serum MOG antibodies with a fixed cell-based assay. We don't have a titer, and it became positive. AQP4 antibodies were negative, and yeah. So after that, we diagnosed him with MOG-associated cerebral cortical encephalitis with seizures, and we did follow-up imaging. This was taken 6 weeks after the presentation to us. By that time, previously noted right temporal lesions were almost disappeared, but there were new clinically silent lesions. And again, after about 5 months of the previous MRI, we repeated, where almost all lesions have resolved. So with this, with the presentation to us, we initially treated him with IV methylprednisolone pulsine, followed by high-dose prednisolone, and then started him on steroid-sparing medication, mycophenolate mofetil. And also because of the significant OCT findings, even though his visual acuity was normal, we did therapeutic plasma exchange 5 cycles every other day, and also given IV rituximab 500 milligrams. So at the moment, patient is on prednisolone 30 milligram on tapering-off regime with mycophenolate mofetil 750 milligram BG, and we are planning to give another dose of rituximab in 6 months' time. He was on levetiracetam, which was started following the initial presentation, and following the diagnosis of MOGAD, by this time he was on prednisolone also for about 3 months. So we thought of slowly tailing off anti-seizure medications after normal MRI brain. But with tailing off levetiracetam dose, he developed another GTC. So we repeated again the MRI brain, but there were no new lesions. So I would like to discuss few points with regard to this case. This subclinical optic neuritis with advanced OCT and VEP findings. Is this something we will see in MOGAD? And then the long-term need for anti-seizure medications in associated cerebral cortical encephalitis with seizures. Maybe we have tried relatively early withdrawal of the anti-seizure medication, which led to breakthrough seizures again. And then the patient with MOG-associated cerebral cortical encephalitis, do they behave differently from other phenotypes? And the place for tocilizumab as a maintenance therapy. I think most of these questions were answered during the symposiums, but I would like to get your expert opinion regarding these as well.
Professor Fujihara, would you like to comment on this? Yeah.
Yes, well, thank you very much for the very interesting case. And so this patient developed a recurrence of the cerebral cortical encephalitis, and different parts of the brain were involved on different occasions. And although the lesions themselves may disappear following the IV methylprednisolone or plasma exchange, some patients may develop seizures. Just a recurrence of seizure, not the recurrence of cerebral cortical encephalitis. So some of my patients continue the anti-seizure medications for a long time. So that's my own experience. And is MOG's cerebral cortical encephalitis behave different from other clinical phenotypes? Well, I'm not quite sure, but some cerebral cortical encephalitis patients may develop a typical optic neuritis later in the course of the disease, so may not be quite different. And as for tocilizumab, there are some reports that the efficacy of this IL-6 receptor monoclonal to prevent or to reduce the risk of relapse in some MOG-IgG positive cases. So if tocilizumab is available, it may be used. And you already started the rituximab treatment. Well, overall, rituximab is effective to reduce relapse in relapsing MOGAD cases, but as was discussed yesterday, some patients with MOGAD may experience relapse, even if the B cell seems to be relatively completely depleted. So that's a striking difference from what we observe in AQP4 positive NMOSD patients who were treated with rituximab. So again, so if tocilizumab is available, you may need to try. So those are my comments. And as for OCT and VEP, Letizia, do you have any comment?
The subclinical optic neuritis in MOGAD is quite underrepresented, but I think it's important to look for it. We had a 60-year-old patient with unilateral optic neuritis, and when we did the VEPs and OCT, we found subclinical optic neuritis, and this prompted us to test for MOG antibodies, and we found them. So there is also subclinical optic neuritis in this condition.
A couple of comments. So if the child did have visual disturbance, the person had visual disturbance in childhood, which was overlooked, isn't it? So there is history of past optic neuritis
Left side
historically. And the other thing is that in children, when they're very small, you're not going to really get any evidence objectively for the parent to know that the patient has a visual loss. At the most, the patient may be irritable, crying, and then over a period of time gets over it, but the scarring is there. So we have no clue whether there was more than one clinical episode of optic neuritis. So we're not surprised about the OCT VP findings. With regard to subclinical involvement, we have seen VP abnormality in patients with MOG positive LETM, for example, and we also seen in the non-optic neuritis involved eye as well, just as you have. So I think it is under-recognized and underrepresented. The other thing is that I think that he has got a lot of treatments. I thought he settled very well with the steroid and mycophenolate, and I think we should have just watched him and seen whether he does well, because mycophenolate works quite well, and large number of my patients with relaxing MOGAD are on mycophenolate after a short bridging with the steroid, and I think we should wait for other options if he does not respond, or as Professor Fujihara pointed out, anticonvulsants need to be given at least for 6 months to a year after an injury to the brain. So these are my comments. Yeah.
I would like to add, Professor Pandit said something very important about the subclinical issue in children. I also performed analysis retrospective in children with MS, and there is a lot of subclinical visual abnormalities, but I think it's simply because the children do not report. So the parents can see them maybe with balance issues, so they refer to the neurologist, and the visual symptom, nobody could say that. So it's subclinical because it's not reported.
Just a quick one. What about the duration of treatment? Is this going to be lifelong, steroids and MMF?
I don't think we have the final answer on how long will we treat. So we
given the fact that he's had some problem in 2011,
yeah,
and it's ongoing.
Yeah, so I would suggest that we need to give him treatment for an indefinite period of time. That's the way I explain indefinite, which could be that either he stops on his own and we have opportunity to find he relapsed, or we are reluctant to take him off the immunosuppressant. That's what happens to me.
Thank you. Thank you very much.
Thank you.
We move on to the next case. Dr. Maithili Aravindan will be presenting that.
Good afternoon. I would be presenting to you about Mrs. R, a 57-year-old female from Colombo. The history starts in 2014. At her age of 48 years, she developed subacute onset bilateral low limb numbness up to hip level with difficulty passing urine. However, the symptoms spontaneously largely improved over a period of 1 month with a bit of residual numbness and urge urinary incontinence, and she did not seek medical attention at this point. Then, 6 years later, in 2020, at her age of 54 years, she developed subacute onset imbalance in walking and visual blurring. Whether there was associated pain, she couldn't recollect at this point of time when she presented to us. Evidence of, on examination at that point, there had been evidence of spastic lower limbs with extensor plantar response. Vision has been normal with no relative afferent pupillary defect. MRI brain and spine had shown multifocal demyelination in periventricular regions, T2 hyperintensities, along with patchy lesions in the spinal cord in the upper cervical and cervicodorsal region, where in the cross-section it looks like partial myelitis. And then at that point, cerebrospinal fluid oligoclonal band had been negative. ESR of 26 was noted. However, she was treated with methylprednisolone pulses with partial improvement of symptoms. And she was kept on oral maintenance prednisolone therapy at that point. Then 1 year later, in 2021, at the age of 55 years, she presents with fever, altered level of consciousness and seizures, where MRI brain had shown that multifocal demyelination again, but without any new lesions. So the MRIs in 2014 and 2020 almost look identical. At that point, again, the basic blood work, full blood count had been, did not show any leukocytosis. Inflammatory markers were largely normal, ESR of 12 and CRP less than 6. A cerebrospinal fluid analysis was done. Proteins were upper normal margin without any sugar drop. There were only 2 lymphocytes. PCR for HSV was negative. EEG had shown sharp waves with periodic complexes. At this point, she was treated with both methylprednisolone pulses and acyclovir, where this encephalitic new presentation had shown complete resolution. Then, by about 2023 or a latter part of 2022, the patient has self-stopped the steroids because of clinical silence. Then she presents to us in the mid part of 2023 because of the persistence of numbness that she had ever since 2014 and the urge urinary incontinence without any new worsening of symptoms. At this point, when we evaluated her, the cranial nerves, including vision, were normal. Acuity was 6/6 bilateral, without any pallor in the fundoscopy, no relative afferent pupillary defect, no internuclear ophthalmoplegia. But the lower limbs still show hyperreflexia with extensor plantar response, but there was no significant weakness as such. Sensory examination, she only showed pinprick sensory impairment in a stocking type manner up to the ankle level with preserved joint position sense, and Romberg's was negative. Upper limbs were completely normal, no cerebellar signs. Memory and cognitive assessment was also normal. At this point, we repeat another MRI, which again shows bilateral cortical T2 hyperintense lesions, but again almost identical to the previous 2 MRIs without any new lesions. There were, in fact, few Dawson's finger-like lesions also with corresponding T1 hypointensities as well. We went ahead and did an MRA, SWI and the DWI, but then there was no blooming in the SWI. MRA was normal. And then, because there was this history of visual blurring also, we went ahead and did a VEP, which showed a delayed latency in the right eye. The nerve conduction, we went ahead and did a EMG nerve conduction also because this sensor impairment was showing a sort of a stocking type distribution, but then there was no evidence of a large fiber neuropathy. Inflammatory markers again were normal. Because of this hyperreflexia, sensor impairment, we looked for any other contributory neuropathy, evidence of B12 deficiency, which wasn't there. Thyroid functions, electrolytes, everything was within the limits. Antibody status we couldn't do because of financial restraints and the patient couldn't afford. So at this point our questions are, is this a case of a burnt out but a benign sort of multiple sclerosis? In that case, is this encephalitic presentation in 2021 compatible with it, or whether it was an unrelated illness that just recovered? And if it is a case of MS, the patient was never on MS-specific DMTs, but then she doesn't have any disabling symptoms either. No clinical relapse in 2020. MRIs are non-progressive. So in that case, is there upper age limit to stop treatment in MS or consider not treating cases that look like MS? Or could this be a variant of a MOGAD antibody-associated disease. And even if the age is not very much in keeping, the lesion location and there were no non-resolving, the lesions have been non-resolving. So even if we go ahead and do the MOG antibodies and show them to be positive, are we going to treat?
Thank you so much for this case. To me, that looks like a very typical MS. I've quite no doubt about that. We have to expect that 15% of the patients have a negative oligochondral band, so it's not surprising. Second, the episode with an encephalopathic presentation was when the patient had fever. And I saw a lot of patients, when they have fever, they have sometimes a very severe condition, usually an encephalopathic one. And the last point is that I didn't see a control of the spinal cord, because the last episodes were more spinal cord located episodes. So probably, even if you don't see lesions in the spinal cord, when you have these minor attacks, it doesn't really matter. It is because they are not so sensitive. And finally, usually, after a certain duration of the disease, there is any new lesion in the brain. So everything looks to me quite regular. The only point is dealing with the treatment. I think that the patient had some episode that suggest some clinical attacks, even not so severe. So in this case, I think the patient is at a very high risk of entering a secondary progressive. Probably it is already in some level of secondary progressive MS. My suggestion is to try to treat with, you have two alternatives. One is siponimod, if this is available. The alternative could be to treat with rituximab or with another anti-CD20. But I suggest to try, because the patient continue to have some new problems. That means some activity, even if you are not able to reveal objectively, but still, as it happens frequently when the patient is in the early progressive phase, all our instruments are not adequate to really pick up what happens. What Okuda told us this morning is clearly relevant.
Thank you.
Thank you. We move on to the last case, which will be presented by Dr. Manuri.
Good afternoon. So I am going to present the last case in the case-based discussion, and it's the pediatric case. So we have a 7-year-old boy who is previously healthy, presented to us with poorly healing ulcers, predominantly over the plantar surface of the left foot. There was pain and paresthesia over bilateral lower limbs with continuous prolonged fever. At this moment, the patient was managed with the pediatric medical team, and we had high WBC counts and suggestive blood picture and high inflammatory markers for infection. And the MRI foot is high stir signal and low T1 signal in cuneiform bones and left navicular bone with post-contrast enhancement suggestive of multifocal osteomyelitis. So they have treated the patient with prolonged course of antibiotics, ibuprofen and other supportive therapy for multifocal osteomyelitis. But patient ulcers and paresthesia did not recover, so he was referred to us. On examination, he had evidence of sensory peripheral neuropathy such as pes cavus and hamartose, and the investigation suggested a nerve conduction study of sensory more than motor axonal type of neuropathy. and we have excluded all the causes of peripheral neuropathy. The ESR, which was initially high, has come down. The genetic diagnosis came as variant of uncertain significance identified in the GNB4 gene of Charcot-Marie-Tooth disease. So along the course of the illness, at the age of 10 years, this young lad complained of blurred vision, and his visual acuity and color vision was reduced. He had a discrete symmetrical P100 latency being prolonged, and his OCT was also evident for previous optic neuritis. This is his MRI obits showing optic nerves and optic chiasma being atrophic, and optic nerves near the globes were blurred, and we had the diagnosis of optic neuritis, which was previous. This is the concomitant MRI brains that we do have, with linear T2 and flare focal high signal changes in bilateral periventricular white matter more on the right side, suggesting of demyelinating plaques. This is our CSF full report, which is normal. There is no pleocytosis, there is no hyperproteinemia. The CSF oligoclonal bands is negative, and we are yet to be traced the MOGAD and aquaporin antibodies. So we have treated the optic neuritis with IV methylprednisolone for 5 days, followed by oral prednisolone tapering off, and he soon acquired steroid-induced diabetes, so we had to stop prednisolone. And we have started IV infliximab. In fact, that is the place where we got the genetic diagnosis, so we abandoned the treatment. Now, his central nervous system lesions are asymptomatic. The interval MRI done in 2023 September shows same features. There is no worsening. There is no prolongation of the bony changes. His inflammatory markers are negative. His optic neuritis has clinically improved, and he is awaiting the repeat VEP and OCT studies. So I have one simple question to ask from the expert panel. Central demyelination with Charcot-Marie-Tooth, do you think we should treat? Because we have read a lot of case reports where they have suggested secondary demyelination with Charcot-Marie-Tooth, because Charcot-Marie-Tooth type 1A is a demyelinating disorder, so there is a demyelination in the central nervous system also. That was one hypothesis that they have suggested. And the second suggestion was the protein mutation creating a molecular mimicry, leading to autoimmune demyelination. That was another hypothesis that has been suggested. Many patients were treated for demyelination, some were not treated. So it was a dilemma for us. Do you think that you can help us?
One point that maybe I lost. When the first OCT was performed,
yes,
there was already a quite clear damage, there was a quite clear reduction, so
yes,
we don't know when the patient started to have
that's right,
visual problems.
Yes,
that
exactly
was my impression, and
yes,
this is a very important point, because yes, if it is related to the Charcot-Marie-Tooth condition, then you should expect that this was a slowly progressive type of condition. Yes. If it was an acute one, then we should think to just an association, but not a link. Okay. So this to me was the major point. But the fact that there was a bilateral damage, yes, not a very acute episode in the history, yes, it really suggests that this is part of the pattern of... and the second point is that the lesions are not really typical. They are a bit, atypical, and they have been reported also in Charcot-Marie in some variants. There are some associated minor abnormal T2 signal. So to me then, considering that there is a high risk of infection on the foot because of the ulcers, yes, I really will be a bit reluctant to treat with any immunosuppressive agent, because we have more risk to induce some increased risk of collateral damage than advantages, unless in the future we can see a clear new activity that may really support that what we see is not just something that is there since a long time. I will wait and see.
Thank you.
Thank you very much, Manori. Thanks. So that brings the case discussion segment to an end. And I would like to thank all 5 presenters and also the international expert panel for discussing the cases. And also we would like to thank everyone who's attended this year's SLCTRIMS program over the last 2 days and also the pre-congress before that. And also profusely thank the international experts, Professor Komi, Professor Fujihara, and Professor Leocani, and Professor Montalban, and Professor Hartun, and of course Professor Pandit as well. So would like to thank everyone. I'm sure you are very hungry now, so the lunch is ready on the other room, other side. Yeah. Thank you very much. So we'll see you in 1 year.